Well, thank you very much for the kind introduction and the invitation to come all the way to Arizona. The weather is better, I can tell you. That's one thing. It was 3 degrees Celsius yesterday when I left, and it was raining. So I think we're better off here. So hopefully this topic will not get you into much of confusion, because it's a difficult topic, and at least I hope you get a higher level of confusion afterwards. What is this? Where are we confronted with immunology? And most of the people nowadays don't know that it has a very surgical and very military background. It was the ARDS lung was called the Da Nang lung, and this was seen first in the and remarkably seen in the Vietnam conflict, where severely injured combatants had a problem afterwards, although they didn't have any lung injury. So that's tossed the question, what's really going on. And nowadays we see this also a lot. This guy got a motorcycle accident, and you see there's not that much injury in the thorax, but severe injuries of the pelvis. And these are his resuscitation values, and you see it's coming from the bottom somewhere there at a pH of 6.8. Basic says of -22 and 14 packed cells in virtually no time. And afterwards, we evaluated further his injuries after he was taken to the operating room to have packed his abdomen. And we had many other injuries in this guy. So ARDS and multiple organ failure are absolutely imminent in this patient. So what is going on here? And we saw indeed that in this patient we had a full-blown ARDS on the long run. And we really don't know what was going on with these kind of patients. And still is a frequent and severe complication, although the incidence is going down. It's overall 5 to 10%, but in multiple injured patients we got 20 to 40% of those patients that get into ARDS. And mortality is decreasing. However, if you have an ARDS 9 out of 10 times, it's more severe, and it takes you a longer time to get off the ICU. So what is happening? We have our trauma, and then we have an increased amount of neutrophils. It's a natural reaction of the body. We get an altered phenotype. We will be back on that. And we see there's a larger number of oxygen radicals into the tissues, and then you get full-blown ARDS. So it's something that's in the leukocytes. We're doing this to ourselves as a reaction on the severe trauma. And because there's some altered phenotype, we thought perhaps we could look at these cells and see whether this altered phenotype could lead us to those patients that are at risk for this syndrome. So severe injury leads to a systemic inflammatory response. This acute inflammatory response is mediated mainly by neutrophils, and this uncontrolled response causes multiple organ failure, and it's the most common cause of death. Well, this is the classic graph that was described by the Moore family. And you see, initially we have the severe inflammatory response syndrome, and then that goes with ARDS and early multiple organ failure. And then we have the compensatory, sometime later, compensatory response syndrome with late MOF and late sepsis. And we didn't know whether these two things were combined with each other. One thing we know is that this is, if we look at the soluble factors, for instance, IL-6, this is normal trauma, and this is multiple trauma. We see the huge elevation of cytokines. And so an isolated fracture, there's no problem, so we can go ahead and do some extra insult on the patient by operating him. With the multiple injured patient, there's a different story. And that's what we see here. The influence of major surgery is more or less not that important for the patient with only a fracture, but it has some definitely influence on the patient that has that's polytraumatized. So we see that polytrauma already has a high immunological reaction, and as we saw, ARDS is imminent, and we have a high chance of multiple organ failure. So is there something we should do with this operative therapy? And this has been a fierce debate for over 30 years now, and the beginning of the 80s, we had some fierce discussions on this, and my mentor, Jan Goris from Nijmegen, at that time was one of the first guys that thought, well, we should operate early on these patients to preclude this multiple organ failure or ARDS in those patients, although there is an extra trauma by our operation. And this was with a beautiful study by Larry Bone and John Weigelt done down into Parkland, when I recall well. And this was a major breakthrough because we could operate patients, well, ready every time the patient hit the OR. So I've been in the OR for 14, 15, 16 hours and, well, operating on these patients and trying to have fixed all those patients with rods and plates and everything until the patient was ready, and then only he had to do or she had to do was to get better. However, this concept was challenged by Chris Pape from Hanover, who was at that time evaluating the results of the polytrauma patients in Hanover. And some guys from San Francisco General know this guy, Johannes Sturm, who was from some time in that hospital and worked closely together with the guys over there. And they together challenged this problem. So they advocated a staged approach. So the strategy, for instance, for orthopedic clearance and orthopedic operations will be different. If you have a stable patient, you go to the OR and you do early total care. If you have a patient in extremis, well, don't fuss around, get them to the ICU, and if you have some orthopedic operations to do, only slap on a fixed X, and you can do even that in the ICU. And I think also general trauma surgeons in the States should learn that. Then we have the unstable patients that go to the OR. We do what is needed, damage control orthopedics, which is 9 out of 10 times a fixed X. But then we have the borderline patients. Those patients are not that stable, but become stable, transient responders, for instance. And then we have to evaluate what is going on. We have our shock room treatment, and then see how this patient is doing. Is he doing well? Then we go well into the early total care. But after each procedure, we have to evaluate and communicate with the anesthetist. And we saw this morning this nice talk from Bob McCursey, that this communication with the anesthetist is not top of the bill in many of our hospitals, but you really should communicate and then see whether you can do early total care or damage control orthopedics. But how can we identify those patients at risk? Correct monitoring is essential. Pathophysiology, however, is not really understood. Therefore, until now, there is no correct identification. The guys from Hanover thought that probably IL-6 would be a nice measure. I'll be back on that. And the current strategy to prevent ARDS is based on cytokine research and provides not a real standard model. And this is this cytokine thing you see. This is a study from Meyer, published in Shock in 2006. And you see the huge amounts of standard deviation. So there is no real difference to make between those that die and won't die. So all those soluble factors are high. There's a high inter-individual variation, and it might be useful for prognostics, but it's not necessarily corresponds to pathophysiology. So what we have been doing is we have chosen to look at the neutrophil. Well, this beautiful picture behind is a scanning electron micrograph of a neutrophil, and all those nice worms on top of it are the feeling arms of the neutrophil. And they can feel a pathogen with its antibody, and they have a special receptor on this effector cell. So we have been looking at that. And what is the mechanism? Is normally we have a neutrophil, and we have this microbe with those antigens, and that goes into those receptors, those Fc gamma receptors, and then it is eaten up by the leukocyte. So that's nice. However, if there's no receptor expressed, or there is a problem with those receptors, then we have a problem that those bacteria grow and grow and grow without getting attacked by the neutrophils. So that was the baseline hypothesis. So we looked at the immune response after trauma in a number of patients, and we looked at the complications and ARDS, for instance. And what we saw that the responsiveness of this receptor correlated very well with the problems afterwards. So this is the normal patient, the non-trauma patient. A trauma patient already has some problems with this Fc gamma receptor. Patients with a severe inflammatory response syndrome got a less good reaction, but the patients with an ALI and ARDS, or acute lung injury or ARDS, are really lacking an adequate reaction to this Fc gamma R2 receptor. And we could, it's not for reading, but we really could see the markers change throughout the inflammatory stage of the host. So what we do now is we try to attenuate this reaction by giving those patients that go for surgery after trauma C1 esterase inhibitor. And what we could demonstrate is that these patients got a lower IL-6 level, and afterwards also a different problem with those reaction on trauma. So we've seen something here, but the problem is we still have something there, and those correlated to each other? We didn't know. Probably we don't know yet. So the question is, who develops septic shock? We again looked at 36 trauma patients with a presumed indication to ICU, and we saw the complications like SIRS, sepsis, septic shock, and death. And we looked at the IL-6, and again, as you saw before, there is a huge individual difference between those variation between those values. And we got the controls. Those the patients that had mild, those patients had sepsis, and those the patients that had septic shock. And when we looked at those patients, we saw generally not a very large difference between the reaction of those patients after trauma. But one value is setting out, and that's the first value on the day the patient came in. We see a very low reaction of the Fc gamma R2 receptor. But the patients that didn't get septic shock are really well receptive. So probably there is some defect in those patients that get into septic shock. But those patients, these are Dutch patients, and probably the Dutch are different people, we thought, and we see there's a nice reaction of and differentiation with those patients that get into septic shock and those that don't have any problems. So we decreased the capacity of the peripheral blood neutrophils to express the active Fc gamma R2 receptor, and I will be back on that. So we tried to evaluate this in another place, and we went to Stellenbosch, where we evaluated this in the similar patient group. And you see, this is the Dutch group, and this is the Stellenbosch group, South Africa group. And the IL-6 levels again had a high differentiation and high individual variability. However, the induced FMLP induced expression of this receptor had a similar pattern than we had in Utrecht and the Tygerberg Hospital in South Africa. So those people presenting on day one with a lack of presenting this receptor went into septic shock days after this first insult. So what is doing a bacteria and a leukocyte? Well, this is a nice video you can get from YouTube, but it very well expresses what the leukocyte is doing with bacteria. You see here a bacterium, and this is the leukocyte. This is going on in your body every day, every second. You see the bacteria is trying to run, and it's running, and is running, still is running, but eventually they got him. So that's what the leukocyte is supposed to do. So when we look at trauma patients and normal patients, we see this difference. We see in a normal patient, this is a way of looking at the receptors on the leukocyte, and we have several antibodies for it. This is CD62, CD16. It's not that important, but what you see, this is a normal patient. It's you and I at this moment, and this is the patient after trauma. And you see there's a difference. And we asked ourselves, what is this difference? What's going on here? And we evaluated that, and we saw that there were differences, and there were several subsets. These are the normal leukocytes, and these are very young ones, and these are the older ones, the hypersegmented. And normal leukocyte biology books, those large, thick books, I can't read, but some cell guys can do that. They say, well, these are the most active and these are the most active. Those are absolutely too young to be active. We'll see. So again, we looked at a trauma patient and we evaluated this. This was the moment where this is the leukocyte count going up to 20 somewhere. And we had on day 4, we had a sampling of that. And here you see the same thing we saw before, but now in this real-life patient. And the problem is that not only we see those younger cells, the banded cells, we see also the matures, that's here. We see, and we have sorted out also the hypersegmented, but also you see here even progenitors. So very early cells that normally only are there where you have cancer. We have shown this to our pathologists, and they said, well, this is a cancerous smear, blood smear. Where did it come from? Well, it came from a trauma patient. Well, and you can imagine that probably there's some difference in how those cells function, and the guys writing those thick books say, well, these are the best ones. These are doing their job. However, they get down in numbers, and these also get down in numbers. And these get in more, and these also get in. So Why are those cells coming out? It's hypermobilization, perhaps, or they're coming out of the bone marrow. Is it exhaustion of the bone marrow? Then we have the banded cells. Those are presumably young cells, as classic neutrophil biology says, and hypersegmented. And even it was suggested that those things come back from wherever in some tissue they went. However, is this good or is this bad news? We didn't know. So the current hypothesis was, overseeing this all, is we have a trauma, and then we have those potent neutrophils. Those are the beta Re neutrophils of blood. So there we go. Those all go to the site of injury, but also to the lungs, for instance. And what we are left with are the crumbling older ones and the very young ones. So that's what we see. That's what we've seen before. So we were asking ourselves, what is the potency of those? How potent are those cells? Evaluating this, we had a very old method, and they are all using that in our microbiology labs. And you see, we have those smears, and then you could have more or less let's say, a semi-quantitative way of evaluating the adequacy of eradication of your bacteria. We have made a new method in which we had a gel where we had those neutrophils and bacteria together. And then we looked at you can feed those bacteria with fluorescence, and if they're living and they're multiplying, you get more fluorescence. And we'll see an example of that. So the more fluorescence there is, the more bacteria growth. And that's what we've seen. So we've put together those bacteria and the neutrophils. And what we see is that if we don't use those neutrophils, those bacteria grow, as they should. They should grow in that gel. However, if we put neutrophils with them, we see they don't grow. There's no increase of bacterial growth. And that even is dose dependent, as you see here. You see 1 million PMNs, you get the problem that those guys get growing, although there are some PMNs. And if you have a lot of polymorphal neutrophils, you see there's no bacterial growth. So, and this is what was happening. You saw before the way the patient had the neutrophil had the bacteria, and here you see this fluorescence. This is within the neutrophil. This neutrophil has eaten a lot of bacteria, and they are contained within the neutrophil. Here you see the number of neutrophils is essential, and the supremacy of bacteria. Those small things are neutrophils. And this green one are bacteria. So there are not too much neutrophils in it. Now you see how quick those neutrophils are trying to get to the bacteria. However, they're not enough. And you see growing of those bacteria. They grow out, and there's a neutrophil lingering around, not doing very much. One of my residents. And you see, he is trying to eat some, but it's not enough. We have bacterial outgrowth. And here we see we have enough neutrophils, and you see enough of these, and they eat some. And you see here, you see nicely eradication of bacteria, and you see the extinction of because of the death of the bacteria, the extinction of the bright green color. And this bacteria has been eradicated. This is going on every day, every moment in your body. So and what we saw is that there is a difference. We have healthy controls, and we have the blood of trauma patients and neutrophils of trauma patients, and we see a difference. So we see that the trauma patient has not adequately enough neutrophils to get those bacteria eradicated. And if we see that this for a trauma patient, we see that also that's also dose dependent. And you see, for instance, 3 million of those neutrophils don't really get an eradication of those bacteria, and 5 million can do the job, although you saw in those other assays that there was a nice way of eradication for those neutrophils. So we have those hypersegmented, those presumably very good and adequate neutrophils in an assay, and we see although they are a lot, they don't move a lot, and you see more and more of those bacteria grow and grow and grow. So those hypersegmented bacteria, hypersegmented neutrophils, that presumably were adequate and the best neutrophils to have, don't do an adequate job. So we have evaluated the adequacy of eradication of bacteria by the different neutrophils we found in the trauma patient, and we see that, for instance, the progenitors aren't any good at all. Although they are massively into the blood, they don't do anything good. Why? We don't know. That's the confusion at a higher level. And then we see that, to our surprise, those young banded cells are doing a pretty good job. But the matures again, they take a long time. And those hypersegmented don't do anything. So there is a change in the population of neutrophils in trauma patients that makes it possible that bacteria can grow, although the neutrophils are there. So we can talk for hours on this, but what we currently think is that we should have to see in our trauma patients on day one. Well, we have to respond to resuscitation, we've seen that, damage control, orthopedics, things like that. And then we have on day 2 and 3 hyperinflammation, so this severe inflammatory response syndrome, which we can see in the number and the adequacy of our neutrophils. And then we have more or less a window of opportunity where we have an adequate number of neutrophils again. And then we have a period of immune suppression where, in our opinion, between 10 days and 3 weeks, no real surgery should follow. So the innate immune reaction after trauma is diminished, is different than in normal patients and in normal persons like you and me. And there are different reasons for that. And I think the treatment should be guided by the immunological condition. However, saying that, I know that we don't have the tools at this moment to adequately discern between those patients that should be operated and have early total care and those patients that we should wait and have some extra measures to prevent septic shock in due time. Thank you very much.